Thank you for coming to my presentation. I hope you can get something from it. So today I'm going to be talking about a patient who had a tibia fracture with severe fear avoidance. So back in September of 2016, she fell at work. She works as a CNA. She had pain in her left shin that initially thought she was okay. She thought she just had some residual soreness, so she didn't immediately go to the doctor. But she eventually went because pain increased with time. So when she went to the MD, she got the radiographs taken, and they were found unremarkable. So she continued to work for about a month. She returned to the MD when nothing else was changing, where new radiographs were taken and a hairline fracture was found on her tibia. She was now referred to us for PT after adequate healing time. We saw her for a total of 25 visits over a 3-month period. So the purpose of this case is just to recognize the importance of integrating all components within a patient's care with a multifaceted past medical history. Also to recognize the role of physical therapy and its effect on a patient's perception of fear or threat, and just to introduce strategy when there's limited evidence-based practice. So I put this slide up here just for a review for everybody that adequate bone healing time calls for a little over a month to 3 months. So let's paint a little picture of my patient. She's 56 years old, female Caucasian. She works as a CNA. She's also a part-time employee at a home improvement store. Her current condition was initially misdiagnosed, and she underwent a traumatic brain injury after having a motor vehicle accident in 1978. She was in a coma for a month. After she came out, she went through rehab, and everything is fairly resolved. And just to make one point, the traumatic brain injury is only a component that made her plan of care more complex. It's not necessarily a focus for today. So the initial evaluation happened in the beginning of December. It was performed by my CI, obviously, because I was not there. So these notes are primarily from his documentation and a little bit of what he told me himself. She was having pain in her lower leg at the anterior shin, ranging from 3 out of 10, described as a dog 8, and worsened with any kind of weight-bearing activities. She came in ambulating with a rolling walker, and her gait pattern was extremely slow and very antalgic. Gross strength on the left side was -4 out of 5, and on the right was -5 out of 5. LEFS is just a general disability with the lower extremities, just as a review. The closer you get to 80, the less disability you feel with that impairment. And as you can see with the LEFS, it's pretty low. So she's finding a lot of disability just because of that pain in her, just because of that fracture. So the first month of intervention, of course, I just want to remind you that this is my CI, not me. He had her go on the recumbent bike with low resistance. She was very deconditioned, so he started her off with that just to get her cardiovascular up. He also did some seated loading exercises and simple weight-bearing exercises, so just trying to shift her weight from back and forth because she wasn't putting any weight on that side. So this is where the fear kind of showed up, and this is where you would find her saying, "Oh, do you think I can do it? I just don't want to fall. And I don't think my legs are strong enough." So repetitively saying this with each and everything we did with her. So here's where I come in. So we started my clinical at the beginning of January. The first couple weeks of January, it was my CI trying to get to know me and my skill level. So the first couple of weeks, it was a co-treatment between him and myself. And by the end of January, she was 100% on my caseload. So I did a reevaluation at the end of January, where she was now having 1 out of 10 pain. still described as a dull ache and aggravated with weight bearing. She was now ambulating with a cane, and a little bit more specific gait pattern that I was noticing was a decrease in uneven step length, decreased cadence, and a lateral trunk lean. Strength was the same. I also incorporated some balance assessments. So what kind of fall risk was she? So I decided to do the Tinetti, where she was 19 out of 28, which is a moderate risk for falls. I also checked her sensory just to make sure everything was groovy there, and it was. So diagnosis via the HIAPA. Health condition was a unilateral tibial fracture, impairments, muscle weakness, altered gait pattern, and decreased balance. At this point in time, she was not able to work. Her environment was very supportive. She had a sister who would bring her to and from therapy sessions. She was also a big motivator when she was at home, trying to keep her active when she was outside the therapy gym. And then remarkable past medical history and highly fearful were some of the personal components. So, why did I choose the Tinetti when I have an array of fear avoidance questionnaires that I could choose from? After working with her for a couple weeks, I based my decision off of a gut feeling. That having her fill that out might have had a negative impact on her. So potentially making her aware of other activities that she was fearful of. The Tinetti allowed me to analyze her ability to perform daily tasks without falling and use it as an indicator of how her fear of falling impacted her physical performance. So her intervention plan, I wanted to see her 3 times a week for 4 weeks. I wanted to improve her strength. I wanted to improve her balance. I wanted to get rid of any kind of assisted device that she thinks she might need. And I wanted to improve her confidence and decrease her fear avoidance. And the ultimate goal was to get her back to work. Second month of intervention. Main categories was gait training, balance, functional activities, and education. So gait training, I wanted to wean her off of any kind of assisted device. So within the therapy gym, I had her do the least amount of assisted device. So at the time when I first started working with her, she was walking in and out of the gym with the rolling walker. So inside the gym, I had her do the single point cane. Then I gradually progressed that to no assisted device at all in the gym. Balance, very simple, getting her on one leg, narrowing her base of support, keeping it nice and simple to start out everything. Functional activities, sit to stands. This is one of her difficult things that she verbally stated to me, so of course, I'm going to sit there and address it with her during therapy sessions when she's got a controlled environment. And then at home, getting her to go on the stationary bike daily. Challenges during the second month. Visit number 9, which was beginning of January, she refused to perform a sit to stand without using her arms. So using her arms obviously makes it easier to stand up from a chair. She thought her legs were too weak and flat out refused to do it without using her arms. Okay, that's fine. Baby steps, right? Visit number 13, inability to perform the bike due to a sore on her bum. So this made me rethink how active she was at home. That day I continued therapy, just kind of skipped the bike because I didn't want to pester her. I thought maybe she was having a bad day and she was using it as an excuse not to push herself that particular day. And as a good clinician, of course, I'm assessing this next time she comes in, and I did, and everything was fine. That next therapy visit. Difficulty with the star drill. So this is a exercise that I was targeting her balance. So narrowing the base of support, you have a resistance band coming away, and you have shoulder flexion with palms facing down, shoulder extension with palms facing up, palms facing each other, diagonals. A lot of steps to it, right? This was not a good exercise for her, and I kind of learned that very quickly. I think with the residual components from her traumatic brain injury, I think the multi-step direction was a little bit too much for her, because every single time she would go and do that, she'd be doing this. I mean, it's not a big deal. You just get a little bit of shoulder discomfort. But having to sit there and go, okay, arms up, palms down, palms up, very repetitive and just not a good exercise for her. So I quickly avoided that exercise and stopped it, just because I could see that she was getting frustrated on her face because she kept on saying, oh, I'm sorry, what was it? And then every single visit, addressing the fear avoidance, hesitancy to perform exercises, short-term memory deficits, difficulty remembering cues, just like with the STAR exercise, repetitive remarks, and then inconsistency with her home exercise plan and lack of trust. So I want to dive into a little bit with the lack of trust. So while guarding her during the balance exercises, no matter how much I told her how well I was trained and working with people of different heights, she's 5'11", I'm not. So there's a big difference, and there was a lot of trust issues with what she think I could handle. So that made me think she's probably not pushing herself as much as she could, just because she doesn't think I can help her if something bad should happen. Okay, what do I do with a person who is so fearful to push herself, and she doesn't have that confidence in herself that she's strong to do all these exercises and doing all these activities that she very well could be doing? I wanted to find if there's any specific interventions that can help me with this. So this is an article by Vistic. It's a systematic review that looked at fear of falling in patients after hip fracture. It looked at the prevalence. It looked at the factors associated with fear of falling, and it showed some evidence on the interventions on how to reduce that fear of falling. And this is what it said. It indicated an association between fear of falling and exercise. Those with less fear of falling spent more time exercising. Well, yes. But it didn't give me any kind of specific interventions in order to guide her therapy sessions. This article talks about exercise intervention and how it probably reduces fear of falling to a limited extent immediately after the intervention. So this is an article that really solidified me having her do the stationary bike daily, just to get that kind of stimulus on a daily basis. This article really gave me a lot of information on what I was doing with her. So this is where things kind of turned the corner. It's an article based off the fear avoidance model, which proposes that the primary affective and cognitive components influencing pain perception is anxiety, pain-related fear, and pain catastrophizing. You have two different responses that you can have: confrontational behavioral response and avoidance behavioral response. So guided exposure, so the exercise where you're progressively increasing the amount of activity that you're doing, leads to, provides the patient with experiential evidence that the previous negative beliefs were exaggerated. So even though her pain was not her main complaint, it was easy to carry over her information from this article and use fear of falling in place of pain. So how did I use this? Well, my CI had already used similar strategies when he chose to do the seated loading exercises. So because she was fearful of doing a sit to stand, he backed it down to doing a loaded seated exercise, which is basically squeezing your glutes together and acting like you're going to go stand up, but you don't actually stand up. I carried it over with the gait training in the sense of slowly integrating ambulation without using an AD or upper extremity support. So with the gait training, I started her out doing basic drills in the gym, using a single point cane at this point, and slowly progressing to, okay, hold on to my hands and we're gonna walk. So she's not having an AD, but it's not so aggressive that she doesn't have any kind of support at all. And then of course progressing to the point where she doesn't have to have anything at all. So next I'm going to be talking about the third month of intervention, but before I do, any questions? Okay, great. What's up?
Did you think about putting an FABQ after you saw that article, or did you do one?
I'll get into it.
Okay. To be continued. Right?
To be continued.
Okay.
So with the third month intervention, it was the same basic categories: gait training, balance, functional activity, just more to another level. So the balance was done on uneven surfaces, head turns, eyes open, eyes closed. Gait training, so at this point she's not using any assisted device in the gym, and I wanted to focus more on specific gait pattern components. So I wanted her to have larger and more even step lengths, and I wanted her to increase her gait speed. So she would have to get from one end of the gym to the next within a certain amount of time. And then at this point, I started to think, okay, what is her ultimate goal? Return to work. So what does she need to be able to do in order to get her to where she's able to do that? So I requested a job description from her employer. And this is where I found that she has to be able to push, pull, move, carry a minimum of 25 pounds, a minimum of 50 feet. She also has to, some of the job descriptions were greet and escort patients to and from their rooms. So in my mind, working as a CNA, she has to be able to push a wheelchair. So this is where I got the push sled out. Challenges within the third month. Visit 19, she had moderate hesitancy with the loaded sit-to-stand. So we've progressed all the way out to where she's able to stand up with a 8-pound medicine ball. One day she comes in and there's the big, larger mats, and then we also have the up-down tables. So the first time it was on the larger mat, standing up with the ball. The very next therapy session, it was on the up-down table for no particular reason. It just happened to be where we were. She did fine with the mat the first day. When I took her over to the up-down table, something went on to where she wasn't able to do it. She had a couple attempts and ultimately told me that she didn't think she could do it. And so I told her, okay, let's go back over to the larger mat. Had her do it. No problems whatsoever. She finished all her repetitions. So it just goes into play. Oh, one thing that I didn't mention. After that second day, I went back and I measured the two tables on how high they were. They were both roughly 22 inches, so there was no big difference within the amount of height that she had to stand up from. So it just goes to show how much of a psychological component everything was happening. And then around mid-February, I completely took the cane away. She was actually borrowing a cane from the therapy clinic. And I said, I'm going to take your cane and we're going to leave it here. And you can walk without it, both to your apartment and all around the community without it. When that happened, she happened to be the last patient of the day. I finished up my notes and she had been talking on the phone with somebody on the parking lot. And as I was walking out to my car, she stops me. Do you think I should go buy a cane? Absolutely not. And then I gave her all these objective measures on how well she was doing. She had been walking on or in the therapy gym without a cane for a good month. And then on visit 25, workers' compensation was no longer authorized. So this last therapy visit was paid out of pocket. And her ultimate goal was she wanted to walk more normal. So I got her on the treadmill. One thing I didn't mention in the very beginning that my CI told me was that he tried to get her on the treadmill within like a couple weeks of the eval. It almost brought her to tears because she was so fearful of it. So we never tried it again. And when I suggested that, okay, let's get on the treadmill, let's see how you do. This would be really, really beneficial for you. She was all gung-ho for it. So at this point, I'm like, all right, we got some progress here. Well, that's good because it's our last day. So she was discharged at the end of February. We ultimately saw improvement within the Tibial score. Still a moderate risk of falls, but still an improvement. LFS had improved a little bit, and so had her growth strength on that left side. And she's now also walking without an assisted device, and ultimately more confidence within her walking without an assisted device. So limitations. Research on precise fear avoidance intervention. So what do? When you don't know where to go with your patient, and there's nothing out there to help you, research-wise. My advice to you is to go to your mentors. Your mentors are your professors, your CIs, your coworkers, your friends, your classmates. You never know what type of tools they have in their toolbox that could help you, because the research that talked about the graded exposure was from none other than Dr. Austin. I emailed him midway through her care and was like, I don't know where to go with this person. This is what's going on. And that research article he sent me, it was ultimately the one that helped me the most. And also keep yourself up to date. So with this research article I found after she was discharged, it's a prospective randomized control trial that talks about a multi-component cognitive behavioral intervention. Multi-component meaning it has guided exposure exercise, it has cognitive restructuring, it also has relapse prevention plan, and a motivational interviewing components to it, all on top of exercise. So take home point, keep looking for the new research because you don't know what's coming out each month that could be able to help you. So with the outcome measure, because I thought there was a negative effect that could have happened with the FABQ, there's really no good answer. It's more of a day-to-day basis of how I came to that conclusion, and that's where I say I got it from my gut. The comments that she made on a daily basis just really kind of just led me to that direction. So, but I also, when I was doing my peer reviews, some of my classmates said, well, what if it could have helped? Maybe if you had approached it to a straightforward kind of scenario, maybe she would have appreciated the fact that you were addressing it head on. Maybe, we don't know. So what did I use as an objective measure for fear levels? So the Vishnik article said that those with less fear falling spent more time exercising. Well, she was spending more time out in the community, aka shopping with her sister. She also spent more time exercising and going to her gym. So that hesitancy or going to the gym because she thinks she's going to fall slowly faded away toward the end of her care. And she was going to her gym and riding the bike more and more and more. And she was also not walking with an assisted device. Patient rapport, the only thing you can really do is make sure that you're being safe and guarding properly just in case something should happen. Because if you're kind of leaning the side of, okay, let's give her some space, and then something awful should happen, she loses her balance and she falls, you automatically have absolutely no rapport with her. So I tended to be on her hip more so, all the way to the point where my C was like, maybe you should give her a little bit more space. while doing her exercises. And then enter reliability with examination findings. That's just referring to the fact that my CI did the initial evaluation, whereas I did the reevaluation. What you got for me?
Did you or your CI ever consider counseling services, like a referral for her with such high fear avoidance?
We had not. Yeah, that's a great point.
I just
Absolutely.
wondered if maybe like that would be something that, which I'm sure you had a great rapport with her, but maybe something that if we do decide to do that with our patients, we might want to just make sure we have the better rapport with them versus somebody that we just met. But I just think maybe she may or may not have benefited from that. I don't know.
Very well, yeah, absolutely. I think if we did do that, I think it may have been more of a factor of a financial limitation.
Sure.
Because she's a workers' compensation and because she hadn't been working since September, maybe, but it doesn't hurt to try. Good question.
I really like the fact that you included the feedback that your peers gave you about sort of pushing you a little bit, that fear avoidance. Sometimes I think, this is more of a comment than a question, but sometimes I think that our own fear avoidance of talking about somebody's psychosocial issues, whether that's depression or fear or whatever it is, can be something that we can learn from. I think probably this is, I'm guessing this is a case where maybe that was a point that came to you at some point.
Absolutely. It was when that peer actually pointed it out to me. I'm like, oh, well, dang it, type of moment. And if I had to go back on anything, it would be to not be so timid and do an FABQ. That's probably what I would have chosen, was the FABQ.
Kind of to be direct about things. And, yeah.
Yep. Yes.
Great job, Taylor. I really liked how you got the job description. I think that's a fantastic idea. But probably not everybody does. You know, when someone's getting something back to work, but how do you know what she was going to do? So I thought that was a great thing to put in there. Did she? I can't remember. Did she have increased strength on your second assessment or on a follow-up assessment?
On the reevaluation that I did, no.
Yeah. Okay. I wasn't sure if she did or not. If she did, because do you think in your sessions were you pushing hard enough to get strength changes, and do you think you needed to? It's kind of a trick question.
Trick question in the sense that
What do you think your primary impairment was with her? I guess is what I'm saying.
decreased strength.
And how did you impact her? What did you do for her? Overall, big picture.
Overall,
Yeah.
I got her fear down.
Yeah. So your primary impairment was really probably more giving her more confidence in what she was doing. So I don't know if it was actually necessary to overload her to increase her strength. I think you set her up in a way that you did a great job with your graded exposure of, okay, let's work with this assistant device. Let's take that away and work with this one, work with this one. So, your dosage around that is, more patient success, right? And so I think you did a really great job of gradually leading into that, and then also taking the time to take a step back and say, why were we met with success on this and failure on this, and going back and measuring the table in the past and all that, just setting her up for the best success that she can have. So I think your primary impairment was probably improving her confidence, and doing some of those things.
That's fair.
Great, very good.
I think overall, if anything, I spent more time with her gait training and her balance rather than the strength component. Just because I was more worried about it, it was more of so I take that back. My primary impairment on the initial question, I think would be more decreased balance.
Yeah.
Because now that I think about it, I spent more time on that. So we had hour sessions with her, and roughly 40 minutes was spent solely on the gait training and the balance, whereas 20 minutes was on the fitnessy type stuff, like the bike and the loading, strength-wise. All right.
Just real quick, now that you know that the balance component, what was the minimal detectable change associated with the balance testing you did? Right, so, and just kind of curious, did you make a difference? Yeah,
9 points, and no, I did not.
okay.
Tonetti,
Right.
no.
Okay.
There was only a 2-point difference within that balance assessment, from a 19 to a 21, I believe it
I
was.
can't remember, that's why.
Yeah, no, there's very minimal difference on the balance assessment. It was still considered a moderate fall risk, so it stayed within that moderate. It didn't go to low, it didn't go to high, so not a lot of change there,
But-
which I was surprised of.
Yeah, certainly enough change with the lack of assistance device at the end, right, going back to the fear avoidance, and maybe that would help with, like you said, had I gone back to do it again, maybe I would have done that fear avoidance questionnaire
Absolutely.
on the front end type of thing. But I like the thought of focusing on her abilities as opposed to let's focus on, this fear component, and it is a balance act, where you start. So, get the job description again here, Dr. Randy said, fantastic. Did she go back to work shortly after discharge? No. Do you know if she's working yet?
No.
Okay. You don't know, or she's not?
She was actually referred to physical therapy again a couple weeks later, but not through workers' comp. Workers' comp still wasn't authorizing it. She was trying to go through Aetna, and if you know anything, Aetna will not cover any kind of medical expenses if it's related to a condition related to workers' compensation. So she wasn't able to come back and see us just because of that matter. So interesting. It was a fun case. So, all right, thank you guys for listening.